Hi, everyone. Thanks for coming. My name's Amy Lopez. I am an adult health nurse practitioner, have been since 2015, and worked primarily in as a primary care provider in geriatrics. So with that being said, I've come across a lot of wounds, and over the last year and a half, I've made the transition to become a wound care provider solely, and became wound care certified about 12 months ago. So with that, I'll get started. Presentation is called Right Wound, Right Time, when allografts make the difference. So just a little tiny background. I know you guys are all familiar with a lot of this. So wounds can be either partial thickness or full thickness. So partial thickness meaning it's only the epidermis, maybe a tiny bit of the dermis, but usually no more than 0.2 centimeters in thickness. And then of course, full thickness can go through through the epidermis, dermis, and then the subcutaneous tissue, even going down to muscle, bone, tendon, all that kind of stuff. With the different partial thickness, full thickness wounds, they heal just a bit differently because of the severity of full thickness versus partial thickness. So partial thickness basically has two ways to heal, two steps in healing. It's the regeneration and then the scar formation. So the regeneration is the inflammatory phase where the extracellular matrix is full of all the T cells and macrophages and things like that to heal it up. And something that's partial thickness, you can expect a healthy person to heal within 48 to 72 hours. Full thickness is a little different. These can be surgical wounds, these can be pressure wounds, these can be foot ulcers, they can be any of those things. And so, as we all know, those are all in their own time frame for healing. But they do go through the 4 different wound healing, cascade of wound healing process. So hemostasis, stop the bleeding. Inflammatory is where the body cleans out and tries to prevent infection, neutrophils, macrophages, like we talked about. Proliferative phase is where you start to have the epithelial cell migration and try to grow in that wound from the outside to the inside. And then you have the remodeling and maturation phase. So also where you have that scar formation. So a chronic wound is a wound that doesn't progress the way it should. It used to be where you would have a very specific time frame as to what would be considered chronic, what would be considered acute. But now we just say a wound that's stalled out and hasn't gone through those stages like the slide before in a timely fashion. And typically, for say like a surgical wound, then you would hope that would be within 2 to 4 weeks. But again, the time frame is dependent on the wound itself. And, some of these wounds that fail to heal and become chronic in nature, they have a lot of underlying causes for that reason. It could be something like poor perfusion. It could be uncontrolled chronic conditions. So, your diabetes, your vascular disease, uncontrolled blood pressure, all those kinds of things can impact the healing of the wound and sort of give it a higher percentage of going into a chronic wound state, as well as chronic inflammation. So inflammation is huge in impeding the progression of wound healing. And so taking down chronic inflammation and the etiology of where it's coming from is going to be really important in trying to prevent chronic wounds or trying to heal chronic wounds. So kind of the standards of the care for wounds. So you're going to have your assessment. You're going to see, where the patient stands as far as how did they develop the wound? Where did it come from? All your HPI, your Your entire history is going to be in the assessment part. Once you do that, you're going to want to understand if there's any infection. You're going to treat the infection if there is, either topically or systemically. And then, possible debridement. A lot of times debridement is needed for several visits before you do anything else. And that's simply just to, one, get rid of any infection that may be there and optimize the decrease of the inflammation. And then two, to get rid of any sort of possible cellular matrix that's covered in bacteria. The other thing you want to worry about is moisture balance. So we want to make sure there's no maceration or spreading of the moisture to enlarge the wound or to impede re-epithelialization from the outside of the wound bed in. Of course, you want to optimize blood flow and oxygenation. So this is where you're going to make sure that people have good blood flow. You're going to do your ABIs, your blood pressures, those kinds of things. Refer off to vascular if needed, or back to their PCP to get that done, that kind of thing. As well as patient education. And then in the end, if all of these things, these traditional standards of care are not working, there's other things we can do, like skin substitutes such as allografts. You can do hyperbaric oxygen. You can do wound vacs, things like that. And these are just a couple of examples of assessment tools that you can use. The push method is specific for pressure ulcers, and then Bates-Jensen is for all wounds. There's a few others out there. There's the time as well, the time tool. But you really just want to find one that works for you and stick with it so that you can be consistent with the patient at each visit and across your patient load. So there comes a time when, this acute wound has now become chronic, or you accepted the patient with a chronic wound already. And there's different things that you can see where you decide to escalate the care and maybe move on to the wound vac or the hyperbaric or allografts. So some of the things are, if you don't see a wound reduction size of, say, anywhere from 20 to 30% in the first 2 to 4 weeks, that can be a sign that you need to move on and escalate the care of this wound. Of course, signs of non-healing, so the wound is getting bigger, there's more inflammation, there's increased pain, there's increased drainage, there's increased odor, and just worsening perfusion or ischemia or anything like that. Those are all signs to escalate care. In addition to having, it's one thing to have a patient with, say, uncontrolled type 2 diabetes, but when they also have, a more arterial disease or COPD and all these multiple comorbidities, that might be a sign to take your standard wound care and advance it. So what are allografts? We've said them a couple of times. This is basically tissue from one individual and you transplant it to another, but it's the same species, so human to human. There's different types of allografts that are not human as well. I've never worked with those, but there's different ways that you can use them. So specifically the ones that I have used are amniotic chorionic membranes, as well as acellular, which are protein-based. And you can see, I won't read that to you, but there's different indications for different types of allografts. And the best thing to do would be to work with your rep or whoever provides these, whoever you obtain them from, and they can really guide you as to what would be the best way to proceed with this patient, and which allograft would be ideal. again, just some indications for them. So these are all escalated levels of care. So this wouldn't be somebody I get day one. I wouldn't go on throw an allograft on them. I would want to, assess them, treat it with traditional wound care, conservative wound care, conservative debridements, those kinds of things. But, there are indications for early allograft treatment, early with, in my opinion, would be 2 to 4 weeks. And then, you can make your plan from that point. Okay, so allografts can do a few things. They can physically protect and provide a barrier for the wound to prevent fluid loss, infection, mechanical trauma, those kinds of things as an actual layer of physical protection. The other thing is that with the growth factors that are in them, specifically the acellular ones, they have the extracellular matrix makeup. So they have proteins and collagens and things like that. And so that all stimulates the wound bed and the host or the patient to sort of create their own cascade of those same things and help to heal the wound quicker through promotion of granulation and re-epithelialization. The other thing that they can do, which is really nice, is that they help with pain. So the pain management is a nice little benefit of these allografts, as well as they significantly reduce bacterial contamination, if applied appropriately. And they are temporary. So you would typically, again, you would need to talk to your rep and decide what is appropriate, but anywhere from 5 to 7 days is when you replace these allografts. And so they're really nice in that you get week to week or week over week, you get this, biological scaffolding for the re-epithelialization and that safety of the physical barrier itself. I just wanted to put this in there because I do outpatient, I don't do inpatient wounds. And so these are what I see every day. Chronic wounds, diabetic, vascular, arterial, post-surgical, and then of course pressure ulcers. Anywhere from, stage 1 to stage 4. This is what I'm sure, as in primary care, this is what you guys are going to be seeing. And so the allografts work for any of these things, so long as the indication is there. Okay, so things to consider when you're trying to decide if your patient is appropriate for an allograft with the wound. You want to sort of think about their overall general health and nutrition. If you have a young, healthy patient who has an acute wound from an accident or something like that, this is probably not going to be necessary because they're likely going to heal just with traditional wound care, judging by their general health. You want to check the immune status, see how people, if there's any immunocompromised people due to comorbidities or anything like that. The A1C is going to be one of your biggest factors in considering if this is appropriate. If you have somebody come in with an A1C, they have a diabetic foot ulcer, they come in and their A1C is 12. This allograft likely is not going to work well for them because of the elevated blood sugar is probably literally going to eat through the allograft itself. And so you want to get that glycemic control in place before you do anything like that. And of course, you want to have some patient education on smoking cessation and that kind of stuff, like you would with any other patient for chronic conditions. So the timing of the allograft placement is important to an extent. So you want to be able to understand, you know, at initial assessment, what your plan is going to be. And so, it can be a simple plan and then it evolves, depending on how the follow-up goes with the patient. Um, like we talked about, it's a physical barrier and protectant. And so if you do it early on, this says within days, and that's appropriate if they get approved. But like I said, I typically don't do that unless it's been a couple of weeks and I can assess that if they will respond appropriately to the allograft. But it does protect and stabilize the wound. So if this is something acute, you don't have a lot of options, there's not going to be very good patient compliance with cleanliness and things like that, this might be a good option for you. If you delay it until you start to get your granulation forming, it can have some odd healing. You can get maybe some epiboly or some rolling and things like that, tunneling. And so these are all things that we want to prevent and not make it a complex wound and sort of prevent how long the wound is going to be in place. Sorry, this is in my way. Okay, again, just the timing, early placement to encourage rapid wound closure, decrease the inflammation. We talked about pain reduction, and then we just want that nice, healthy, beefy wound bed. If we wait in applying these too long, we could have biofilm formation and contaminated wounds. The patient can start to become poorly perfused in that area. We can have some maceration, and then, like we talked about, epiboly, some tunneling, which we don't want to have, and can really impede our healing process. This is just a slide that you can take to sort of have an idea of how to put it into your actual care plan. I'm not going to read it off to you, but these are different things that you want to take into consideration as far as the clinical presentation, and then how the allograft can be applied into that part of the presentation. We've talked about several of these things already, but really it's all about maintaining a clean, moist wound bed, and creating an ideal bed for the allograft for wound care in general, to try to create that granulation and that re-epithelialization. That's really what it's all about. So, some expectations for the allografts. Like we said, we can protect the wound, prevent bacterial contamination, help prevent fluid loss, and then stimulate through the different amnions and chorions, proteins, collagens, things like that, the granulation tissue and the re-epithelialization. So an optimal wound is going to be clean, it's going to be vascular, and it's going to be free from contamination or maceration in the peri-wound area. And that would be your ideal wound to apply. Again, sort of repeating the same kind of stuff, wound bed response, infection control, moisture control, pain and inflammation. These are all things that we want to see happen and improve with the placement of the allografts. If you're not seeing results with the allografts, then it's probably a good thing to stop using them, and then just reassess and kind of start at the beginning again. You can always, if you need to get cultures or anything like that, those are all options that you can do anytime within this time frame. The allografts don't prevent you from providing wound care in the meantime over the next allograft placement. A lot of my patients have home health, and so home health is there twice a week. I'm there once a week, and so they're still being seen 3 times a week for wound care. but leaving the allograft in place until I come back. This is just an example of one of the allografts that I used. So this is my patient who had a post-Mohs surgery. I hope you can see it well, but right here on his up next to his left ear was the surgical site. And typically these heal pretty well, but he was asking me for help because it was really painful and really irritating for him. And it was starting to become more inflamed. And so I saw him a week later, placed one of the allografts. This one is an acellular allograft, so it's a protein-based one. And then, as you can see, just 1 week later, it was completely gone. Within 48 hours, he had no pain, and it just works really well if it's used for the right indication. This is from BioWound Solutions, so there's lots of different companies that sell. There's been a lot of changes with Medicare recently, so you're going to see a lot of companies fall off, but these guys are going to probably be around for a very long time. So there's that. So excuse me. Documentation is huge in getting reimbursed for these allografts. First, you have to have a prior authorization. The only ones that are approved right away are Medicare, traditional Medicare red, white, and blue cards. Managed cares are not approving these right now unless you provide documentation for 4 weeks of traditional wound care, which I've done several times and they still deny it. So, right now it's just Medicare. But you want to show that you've been doing for 2 to 4 weeks regular sharp or mechanical debridements. You can do, with your dressing changes that you've addressed infection. You've recommended offloading if it's a diabetic foot ulcer, or compression if it's, like a vascular injury that you've deemed appropriate to have compression. And then you document patient compliance as well. And then at the end, you say, despite adherence to standard wound care, this is what I would recommend. So, documentation, as you all know, is the key to everything. And this one is no different. So, essentially, you need the right wound in the right time with the right patient in order to put that allograft on and be successful with it. I've had, 90% success rate with these allografts, as long as it's within this, takeaway. They're a really great option. And I would recommend them if you have the ability to do so. And I think that's about it. Let me stop.
Questions?
So you were talking about timing, and a lot of these you put on after a couple of weeks after they first come in with the wound, but they require a prior auth as well. When do you, how long does it take to get that process out and actually get the allograft in your hand to be able to apply? And how far ahead of time do you start trying to get it approved?
Yeah. So if it is that traditional red, white, and blue Medicare card, I can get the approval in 24 hours. And I can get the allograft in my hand in 48 hours. If it's the other ones, I've yet to get approval.
Any other comments or questions before we can get ready and wrap up and close? Okay, yeah, so thank you, Amy, so much for that talk and all the information. All right, everybody, thank you for joining us.